affecting women of all ages. The prevalence appears to be rising because of the current epidemic of obesity. It accounts for 90 to 95% of women who attend infertility clinics with an ovulation. Unwanted facial hair and bodily hair, acne, obesity, and infertility have profound effects on the quality of life for these women. Next. So we'll discuss a case. Here is a 28 years old patient who's been married for 3 years and she's been trying for conception for last 1.5 years. Her cycles have been 4 days by 50 to 60 days, scanty in flow. On examination, she's a young patient with mild hirsutism. Acne is present and her BMI is 28. Next. So as far as investigations are concerned, all her investigations, routine investigations are normal. Her LH-FSH ratio is 2:1, which has been reversed. Total testosterone is 56, which is also at the upper limit. Her ultrasound shows mild features of PCOS. HSG shows bilateral patent tubes. And the semen analysis of husband shows the count as 26 million. And motility, grade A, only 35%, and morphology, 40%, normal. Next. So what is the diagnosis and what other investigations are required to confirm the diagnosis, Dr. Kirti?
So, ma'am, with the clinical history, we can make out that she is having either oligo-ovulation or anovulation. Especially the LH and FSH ratio is ulta. आवाज आ रही है ना मैम?
हाँ आ रही है.
हाँ. So yes, and rest of her parameters are normal. So for that we need to evaluate her. Like you have already evaluated her hormonally. So according to me, she is in oligo-ovulation or anovulation. And for confirming, I will just repeat her FSH and LH to confirm the diagnosis, as well as go for an ultrasound to find out what is the status of her ovaries. अभी तो आज मैंने एक वो नया सीखा है. Which Anita ma'am has said, number of follicles per ovary. I'm using a wrong term for that. So for that, वो देखेंगे और उसके accordingly we'll try to manage her. We'll do detailed hormonal profile for her.
FNPO.
FNPO, yes, ma'am.
So from here we can see that oligoanovulation. Previous slide, Malvi. Previous. Oligoanovulation, hyperandrogenism, and polycystic ovarian morphology. Any of the two criteria, if they are present, it is considered as PCOS. Next slide. So this is the ultrasound picture which we see. Next. So diagnosis of PCOS can be made only when other etiologies have been ruled out, as we have already been discussing, like thyroid dysfunction, congenital adrenal hyperplasia, hyperprolactinemia, androgen secreting tumors, and Cushing syndrome. All these things we've already discussed. What all tests are to be done. So it is just a revision. Next. So these are the things which we find on getting the test done. Next. So what is the role of AMH in the management of PCOS, and what are the reasons for infertility in PCOS, Dr. Neerja?
Yeah, as we have already discussed, that AMH is an independent marker. Like, no, it is not important in adolescent, but it is important in adults. And along with FNPO, if we are taking it, it is an important marker, and it is rather a diagnostic tool that is biological, objective, and quantitative marker, and it is not affected by day-to-day periods. So it is important, and generally it is raised in PCOS patients, and that causes hyperandrogenemia also in the patients, and AMH is a good tool to treat the infertility patients.
Although AMH is not used to diagnose PCOS, but it is very important. Then once AMH is very high, then we have to be cautious in stimulating ovaries, and controlled ovarian hyperstimulation, OHSS chances are much more if levels of AMH are more. So we have to be very, very careful in giving ovulation induction in these patients. And why PCOS causes infertility? Because of the poor oocyte quality. Endometrial receptivity is also not good. There is hyperinsulinemia, and it affects gestation. Although these patients may also be developing gestational diabetes and hypertension, as we've already discussed in detail. Next. So how will you manage her? What is the role of ovulation induction in PCOS, Dr. Ila?
Yes, actually, she is an adult PCO, and naturally, she is trying for fertility, conception. She is already trying for 1.5 years. So, mostly, she has come in a time when we have to do some active management in her case. She must have gone through follicular monitoring or whatever. So, we have to do a ovulation induction as the first place. If she is on metformin or some other drug like that, then of course we have to see whether she is ovulating or not. If she is not ovulating, then we will start with the letrozole. That is the first line of treatment. If letrozole fails for 3 to 6 months, if 3 months, if you try. Another thing I want to say, that in this patient you have to do an IUI along with the letrozole, because she
Control.
has a semen analysis is not good. It is 26 million. So apart from lifestyle management and all those things, diet and everything, she is, I think her BMI is also 38, I believe. Is it so?
No, it is
BMI
not 38, it is 28.
28.
Yes,
Okay, so slightly higher.
slightly higher.
So in this case, we have, because she has already tried for 1.5 years, so you will have to try for a little while, and then you have to take help of assisted reproductive technology initially, after doing induction of ovulation with letrose or whatever medicine you feel like, and along with IUI. So if it fails in 3 months or so, then she can go ahead for IVF.
Actually, she is in a younger age group. She's just 28 years old. So we can, and also she gives history of irregular cycles for 50 to 60 days. Maybe we can guide her about the timely intercourse also. So one cycle, if we are monitoring her natural ovulation, we can come to know whether she's ovulating or not. In case she's not ovulating on her own, we can induce ovulation. Plus, we can guide her with the help of ovulation studies that timely intercourse is very, very important. And if in case she does not conceive in a matter of 2 to 3 cycles, then uh, we should give controlled ovarian stimulation plus IUI should be done for her, because male factor is also there. Next. So, in previously, whenever anybody used to come for infertility, having PCOS and obese patients, we used to tell them to decrease their weight. But nowadays, since the age at marriages has increased, and whosoever comes with the problem of infertility, they are in a hurry to conceive. So we cannot guide them that first reduce the weight and then come back and then we'll treat you. So the treatment has to go simultaneously. They are guided to reduce their weight, as well as ovulogens are recommended to enhance the fertility. Next. So this is the overall logarithm, which shows that for a PCOS patient, when we have diagnosed with the Rotterdam criteria and ovulation has been detected, then we should wait for natural conception. We can wait for 3 to 4 cycles. 6 to 9 is written here, but I think that is too long. One should not wait for so many months. And in case ovulation is not there, then she should be given full fertility investigation should be done, and insulin resistance should be ruled out. She should be guided for lifestyle management, and then letrozole or clomiphene should be given according to the requirement. Next. So insulin sensitizers, Vandana has already spoken about metformin, as we've already seen that once the patient who is not ovulating properly, if we add metformin along with the ovulogens, the ovulation rate and the pregnancy rate is much better in these patients. Next.
See, doses of metformin should be started from the
We should
minimal,
start from
not
low
with the
dose
1500.
and
Either start
increase.
with 500 or 1000 milligram in a
Yes.
day, only then increase.
Next, Malti, next slide. Next. What is the choice of ovulogens, and what is your choice controlled ovarian hyperstimulation with IUI or IVF for this patient? Anybody can take it.
Ma'am, the choice should be we should try to controlled ovarian stimulation should be our choice, and we should start with the clomiphene. और जब तक मैम nowadays when the patient till the time the patient reaches a doctor, she has already had some cycles of induction, so we have to see कि clomiphene से ovulation हो रहा है या नहीं. Otherwise one must go ahead with letrozole. I particularly use letroz only, ma'am, because clomiphene se there are problems like there will be thin endometrium and there will be multiple
First line of treatment is letrozole in PCOS. First
yes,
line
ma'am.
of treatment is letrozole, not
So we
clomiphen.
can so we can increase the letroz dose if even if on the 10th day we see that there is no follicle, we can still add on like 2.5 milligram daily. And otherwise, if the patient is convinced that she's planning to go ahead with IUI, or then we can use gonadotrophins also from the beginning itself. In the induction itself, we can use gonadotrophins.
Multi, please, next slide. So this is the dose and protocol for letrozole, which Kirti has already said. So we can start from the third day of the cycle, 2.5 milligram for 5 days. A stair step or an escalation protocol can be followed, according to which when we have already given letrozole for 5 days, then transvaginal ultrasound is performed on day 10 to assess follicular recruitment. If no follicle more than 10 mm is observed, immediately increase the dose by 2.5 milligrams of letrozole for additional 5 days. The escalation protocol increases ovulation rates. So if we see that no ovulation has occurred with this, then gonadotrophins should be added for the desirable results, so that no time is wasted in causing the ovulation. So once the ovulation we have documented and the patient has not conceived, then she should be referred early for IVF instead of wasting more time and spoiling more follicles. Next. So what would have been the management if she was 32 years old, Dr. Seema?
Had the patient been 32 years old compared to the other age 28 years, since she is advancing age, so we would not like to advise her or counsel her for a natural conception, diet and all much. We should be advising her for ART procedures early in the treatment part, so that she doesn't waste much time in natural conception and she manages to conceive early and within the limited age that she's entering now. Also, the male factor has to be kept in mind, because the male factor is also not very good. So ART procedures would be a better option for her early.
So in conclusion, the first line of treatment is lifestyle improvement, weight reduction, exercise, no smoking, no alcohol. Then inositols may improve insulin sensitivity, ovulation rate and oocyte quality. Melatonin can be added for regular sleep. And it has been seen that if melatonin, vitamin D and vitamin B12 are added, then the rate of conceptions are better. The metabolic and hormonal milieu should be as physiological as possible, and exposure to pollutants should be kept to a minimum, particularly in the periconceptional period. If a pharmacological treatment is necessary, the same advice could accentuate the effects of drugs and or reduce their risks, like multiple pregnancies or ovarian hyperstimulation syndrome. So we have to take care, neither too little a dose nor too much of a dose should be given, so that we obtain optimum results. That's it. This is a short panel. It was just a revision of whatever Vandana and Dr. Anita had said.
I have a question.
Word
Anybody
about
can answer it.
laparoscopic ovarian drilling. Dr. Anita has already given the guidelines that.
नहीं, एक पहले मेरे सवाल का जवाब दो.
हाँ बताइए.
AMH उसमें जो नई गाइडलाइंस है उसमें लिखा है कि AMH is variable throughout the cycle.
Yes.
So what is the best time to do AMH?
They are coming back to same that even between day 2 and day 5, like we are doing LH, FSH and all, do it on those days only for making it more readable, or maybe from across the cycles if we are measuring. Suppose we are going for ovarian surgery and I want to measure AMH.
वैसे यूजुअली कराते हैं तो हम लोग उसी समय, क्योंकि एक साथ ही कराते हैं, सारे कराते हैं, थायराइड, प्रोलैक्टिन सब डे 2 पे ही होते हैं.
Yeah, initially it was said it can be done on any day of the menstrual cycle. But now
in this case, ये जो रेनू वाला केस है इसमें AMH नहीं कराया हुआ था.
वो कहते हैं तो आपको कॉन्टेक्स्ट में लोग कब कराया.
रेनू वाले केस में थायराइड और वो भी नहीं हुआ था ना.
नहीं, इसीलिए तो मैंने पूछा ना, what all investigations, what more investigations you require?
Ma'am, what is the cut-off level of AMH?
I missed them.
उसमें बहुत सारी चीजें.
I missed them deliberately because I wanted you to point out that thyroid needs to be done prolactin levels needs to be done, and AMH
And OGTT was also not done.
OGTT was also
ये
not
तो
done.
इसने पुरानी गाइडलाइन से
इसीलिए
बनाया,
मैंने
लेकिन
बोला था, इसीलिए तो मैंने बोला था what all investigations you want to
मैम
add.
लेकिन OGTT करा के हम लोग क्या करते हैं, लाइक उसके सब लोग कराते जरूर है, फिर करते क्या है उसका?
नहीं
सुनो
करोगे
मेरी
क्या?
बात
अगर
सुनो।
अब नॉर्मल है तो
You will know ना कि what are the blood sugar
तो पहले
levels.
भी ले लेते हैं।
नहीं, I want to tell you, सुनो
OGTT अब नॉर्मल है तो मेटफॉर्मिन ऐड करोगे नंबर
नहीं,
1.
Metformin add करोगे ना.
या
OGTT only तब कराएंगे जब पेशेंट या तो फर्टिलिटी के लिए जा रही होगी या एडल्ट एडोलेसेंट है, मतलब लेटर एज ऑफ द एडोलेसेंस. बहुत यंग एडोलेसेंट में OGTT नहीं कराते,
OGTT is essential.
लेकिन उसमें HbA1c is must.
जरूरी है. आप
Essential है, ma'am.
मैम का
AMH is essential
मैम
now. It is an essential investigation.
Ma'am, if AMH level is
can I make
5.5,
a comment? Can I make a
ovarian
comment?
stimulation should be
Dr.
done or
Neeta is
not?
asking something. Dr. Neeta is asking. Yes, Dr. Neeta.
Ma'am, if AMH level is 5.5, ovarian stimulation should be done or not? Like what level is the cutoff for ovarian
Guarded.
stimulation?
Have to be guarded for that. You will do. Patient is not.
As far as AMH is concerned, in PCOS patient, anything more than 3.5, you have to be very careful when you're stimulating these patients, because any if you find in the crop is of more than 15 follicles, are starting
OHS
small and bigger one, then you'll have a problem. So I think in such cases you must see both AFC as well as the AMH when you are starting the cycle. Now, but here I just wish to tell you about infertility treatment, whether she's 28 or whether she's 32. I think, when patient comes to you, she has had tried 3-4 cycles outside and she's coming to you, you have to be very clear that when she has come to you, you are giving an ovulogence to her. If the GTT is abnormal, 75 milligram, then you will add metformin in case if it is abnormal. IUI has to be taken very seriously. One IUI is 10% success rate. If you have done 3 IUIs, is equal to IVF. If you give proper monitoring to such patients, proper counseling to such particular patients, giving them a proper advice that every 3 days they should have relationship and then they supplemented with IUI, I think it makes difference. Now, please, if you're doing only follicle monitoring, plus you're giving ovulogens, it is 6%. But if you're combining with the IUI, whether you will do letrozole or clomiphene, it is 8%, 8 to 10%. But if you're combining it, very guardedly, if you give combined ovulogens plus gonadotrophins, it will be 12%. But if you're giving gonadotrophins plus IUI, it will make to anything between 17 to 20%. So I think, these 3 cycles of IUI, which is at your time you're doing it, it's just to be taken very seriously. And if you're serious, she will conceive during this particular time. But if she's the phenotype is that she's unhealthy and her BMI is more, in that particular cases, she also knows that she will probably require, अगर इसको conceive होना तो 3 conceive हो जाएगी, उनको नहीं conceive होना है, तब this is one particular patient who is going to require IVF. So I think, just first 3 cycles of IUI when patient has come to you, don't waste that particular time. Spend little more time with patient, and the success is here. Success is here. One has to be very careful about it. Anything pertaining to IUI, please ask me now.
Ma'am, like in this patient, the active sperms were less and the count was also borderline. So we should
Count was 28.
we should use for
Count
IUI.
was 28 was good enough.
As for the count today is concerned,
Then
it is
20.
anything more than 15 million is a great
Yes.
count.
Good count, yeah.
Is a great count.
Okay.
The motility is anything less than 10% is bothersome. But she's a 40% motility, कोई घबराने की बात नहीं है.
Yes. Morphology was also good. 40% was good morphology also.
See,
Ma'am,
the question, yes.
Ma'am, can we combine letrozole with HMG in such patients?
Yes.
Why not?
HMG तो देनी नहीं
it's the same
PCOS
thing.
में.
नहीं HMG दे सकते हैं. HMG
Along
दे
with
सकते हैं.
letrozole.
अगर LH बहुत
And
हाई
let
नहीं
me-
होता.
let me be very frank with you. Gone are the days when you were advocating only FSH. Now, majority of the time, people are using HMG unless you're using a pure gonadotropin. In that case, first 5 days we give FSH. In combination, we always give HMG.
HMG.
Anything
Thank
else?
you.
Please don't forget 3 IUI cycles are equal to 1 IVF. And level 1 level जो manage करते हैं fertility clinic, those gynecologists should be very clear that you should not lose this opportunity of 3 IUI with yourself.
Yes, yes, very good, ma'am. That's very good point.
Thank you, ma'am.
Thank you, thank you.
So I hope
And I think the new guidelines are
else?
very clear that any patient who falls in a category of obese means anything have BMI is more than 27. Then in that particular cases, you must get a 75 milligram test done.
OGTT.
And in case if you find it is abnormal, impaired, or there's a gross, then you must add metformin. These new guidelines have very clearly said that addition of metformin, previously it was not advocated. Now this has made it very clear that metformin is equally important.
Ma'am, now it has been documented that you document insulin resistance and give metformin. But
मैडम इंसुलिन रेजिस्टेंस का कोई टेस्ट नहीं है, वो कहते हैं कोई
OGTT, sorry.
75 मिलीग्राम ग्लूकोज
Abnormal OGTT. Initially, metformin was added empirically if the patient is not responding to CC. So that was the reason why it was said that you add metformin, or now it has been very clear that OGTT abnormal, she is dysglycemic, she needs metformin because of her metabolic problem.
Secondly, उसकी कमर जरूर ध्यान करो, उसकी हाइट से उसकी कमर आधी होनी चाहिए,
वो आजकल तो
हाइट से उसकी कमर आधी होनी चाहिए. Central obesity is a problematic. यहाँ पर उसको बताना पड़ेगा.
Ma'am, sometimes lipid profile is also deranged. Then shall we add
प्रोफाइल तो आप डॉक्टर साहब अनीता ने ये समझाया है. लिपिड प्रोफाइल तो पहले टाइम में सब जो आया, चाहे वो एडोलेसेंट आए, लिपिड प्रोफाइल
नहीं मैम, अगर deranged है तो what do we need to add statins? That is what I'm asking.
स्टैटिन की कोई
Exercise, lifestyle
Lifestyle
management.
changes से हो जाता है.
dietitians are have to be there. They have to be
Fiber. Fiber.
diet, lean proteins, and low fat diet.
Fiber, yeah.
डॉक्टर स्टैटिन्स हम लोग इनफर्टिलिटी में बिल्कुल यूज नहीं करते.
नहीं, not used.
We are not using.
Adolescent में भी नहीं, infertility में भी नहीं.
Good evening, Dr. Sharda.
Yes.
Yeah, Dr. Neha, go ahead.
Yeah, I just want to ask, what is the protocol of giving gonadotrophins with the letrozole in IUI cases?
Let me very frank with you is that हिंदुस्तान के गायनेकोलॉजिस्ट ने प्रपोज कर रखा है ओवरऑल ओवुलेशंस प्लस गोनाडोट्रोफिन्स. आपने कोई भी वेस्टर्न फिगर आए अदर देन आउटसाइड इंडिया, वहां पे कहीं पर ये कॉम्बिनेशन यूज नहीं करते. हम ही लोग एडवोकेट करते हैं. दूसरी चीज ये है कि आपने अगर यूज करना है तो आपने लेट्रोजोल आपने यूज कर लिया. इन पेशेंट्स को आप नॉर्मली 3rd डे यूज करेंगे. 3rd डे दिया, 4th डे दिया, 5th डे दिया, 6th डे दिया. मैडम ने बताया कि आप 10th डे करें, पर अगर आप गोनाडोट्रोफिन्स यूज करना चाहते हैं तो वंस यू फिनिश लेट्रोजोल यू हैव टू स्टार्ट गोनाडोट्रोफिन्स एंड पहले कहते थे alternate days, then नहीं, it has to be given on a continuous basis. But if the follicle size is more than 14, then you need not give. अगर endometrium भी बढ़िया सब कुछ अच्छा तो you can stop it after that. तो एक बात है, ये जो alternate days गोनाडोट्रोफिन देते थे वो भी गलत चीज है. IVF में कभी ऐसा नहीं होता. तो आपने ओरल ओवुलेशंस यूज किया, उसके खत्म होते ही आपने गोनाडोट्रोफिन यूज करना. अगर आपके रिक्रूटमेंट में प्रॉब्लम है, अगर रिक्रूटमेंट प्रॉब्लम है तो बीएन चक्रवर्ती कहा करते थे 2nd डे भी आपने गोनाडोट्रोफिन देना 1 डोज, तो उससे क्या रिक्रूटमेंट ज्यादा हो जाएगा.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you.
Word on ma'am, bariatric surgery.
As far as the weight reduction is concerned, 5% weight loss also does wonders. Harmonically, it does lot of this thing. थोड़ी inflammation भी कम हो जाएगी, insulin resistance भी कम हो जाएगा. They will definitely do it. But I feel कि earlier you should do it. Patients are reluctant for bariatric surgery. But my experience of over 60 cases of bariatric surgery in my cases is that majority of the patients who are not having periods, they were having periods 6 months, 9 months, they start having regular periods.
Weight reduction is most important.
And they start having regular periods and on their own they conceive. So 70% conceive on their own.
Vandana ji, there was a guideline about this also, because if your patient has presented with infertility and you have advised her bariatric surgery, there are specific indications like she's not able to reduce weight for any reason and she has not responded to medical treatment. Now you have advised her bariatric. Now the patient will have to wait for at least 12 months once you
Advise the
restart her infertility
Minimum 12
management.
months. Because
Yes.
after bariatric
Says
surgery,
bariatric
she has to
surgery
wait
has
for
a
12 months, because then also micronutrient deficiency will go off. If she conceives earlier than that, the bariatric surgery का भी सत्यानाश हो जाएगा.
Yes.
मैम
And
FGR
more,
हो जाता है, प्रीटर्म डिलीवरी हो जाती है, बहुत सारी प्रॉब्लम्स
yeah,
आती
yeah,
हैं.
yeah. They have proper
they
gestation.
are so categoric in defining that once the weight stabilizes after bariatric surgery, then patient can go ahead with
Even
infertility.
then,
And
they
bariatric
say,
surgery के लिए भी आप मान के चलिए 80% of the extra weight will go away in 12 months time. किसी ने नहीं कहा आज bariatric surgery कराओ कल weight कम हो जाएगा.
Yes.
Time लगता है.
Ma'am, thank you so much for this
So-
beautiful, it was an academic treat. Thank you. Wonderful panel discussion. Thank you. everybody.
thank
So
you.
I hope that the information we have exchanged today will benefit us and all
Thank
the
you.
patients. As we bring this exceptional webinar to a close, I would like to thank Dr. Sharda Jain ma'am, Dr. ANITA, RAJORIA, Dr. Vandana, Dr. Renu, all the distinguished panelists and the chairpersons, Dr. Sangeeta, and all the attendees who have largely benefited from this such an exceptional webinar. Thank you so much. Thank you everyone.
Thank you, and then see you.
Bye-bye. Take care.
Bye bye.
Thank you. Thank you.
Thank you, ma'am.
Thanks a lot.